We are live. Welcome to our today's special webinar. So we are waiting maybe a few moments until the other colleagues have joined. The room is filling up. Very punctual. Maybe you want to share in the chat where you're from. It's again an international webinar. From which country? That would be interesting. We just turned back from Milano, from the EAO meeting. Maybe I've seen some of you there. So please share in the chat if you want where you're from. That would be very interesting. And we have Loreen Shala from Spain. Hello. And Raul Siladi from Romania. Wonderful. Implanto Days. I've been there recently as a speaker. Very interesting. And we have Mayola Davidi from Albania. Hello, good evening. Mohammed from Syria. We have Anastasia from Sweden. Christoph Avilo from Poland. Christina Kirilova from Bulgaria. Great that you're here. Horia Pantea from Romania again. Uncle Georgia from Bulgaria, Daniel from Iran, Daria from Latvia. Really international today. Wonderful. I'm excited because this is really a very, very special webinar. If you have any colleagues who want to join, this is really a premiere. Tell them, send them the link. They should attend that. That's actually a special webinar. We are waiting for that since 9.5 years to do that. Daria from Poland, Brahim from Tunisia. Oh, I will be there in December as a speaker in Tunis. Looking forward to that. Simon Klimasewski from Poland. We have Nur from Syria, Renata from Bulgaria again, Stefan from Serbia, Valdis from Lithuania, Hassan from Cyprus, Branislav from Slovakia. Great that you're here. And Elbasan from Kosovo. We have Sylvain from Canada. Christopher from USA. Sharmila from India. We have Selahadin without city or country. We have John from also United States. We have Moti from Israel. And Brahim again, Tunisia. Joseph from Slovakia. Aiton from España. Wonderful. That's really international. That's how I would call it. Perfect. And before we are starting now with the premiere webinar, I want to do a small poll with you, a small survey, because I'm always interested if you have already experience with working with autogenous bone yet. So the question is, how many blocks did you harvest so far? Did you collect so far? So please be honest, and you have the option either 0, never, or 1 to 5, or 5 to 15. So the poll is starting now. I give you 20-30 seconds, and then I will share the results. And most never harvested a bone block, but that's probably why you're here today. And we have 20% who harvested 1 to 5. Now it's changing a little bit. So we have now 50% approximately never harvested block. We have 25% 1 to 5 blocks. We have 10% 5 to 15. And we have 2 to 3% more than 15. So really some experts also. I will end the poll. I think you should see the poll now. 50% never harvested block and 23% 1 to 5 blocks. So that means we have more than 70% of you who are in the beginning phase, and probably that's why you're here to get more information about that. It's wonderful. Perfect. Now I need your help because once we had a problem with the connection. So please put the number 1 into the chat if you can see my screen. So please just put the number 1 into the chat if you can see my screen, just to give me a quick feedback. By the way, you might see now the chat field, and besides that, there is Q&A only. The first number 1s are coming in. Thank you so much. Little delay. Okay, now a lot of number ones. Wonderful. That means I'm really online now with my presentation. Thanks so much for your feedback. Good. I go into the presentation. My name is Frank Zastrow. I'm working since more than 12 years now. No, I'm wrong, 15 years. So I started in 2009 at Professor Fouad Khoury. 15 years now with purely autogenous bone. So we're working in our clinic only 100% with autogenous bone, as many real bone builders over the world are also doing this. And as I said before, this is really premiere. Bring all your colleagues to this webinar, because in the end, I have a very, very special offer also. You cannot refuse. Good. What will be the program of today? I will share the Semilunar technique. Probably many of you have seen it already on social media, or maybe on conferences where I gave lectures, or maybe from other colleagues, they have talked about that, with the Easy Bone Collector for safe and fast bone harvesting. So this brings bone augmentation regarding simplicity to a complete new level. I will share some case presentation, and then, I have a very special premiere launch offer for you. Some of you might know already my Real Bone Builders Facebook group with meanwhile more than 16,000 colleagues following us. They are sharing their cases. I'm also on Instagram. Please tag me there. Also, if you have cases, I will always reshare your cases as long as they are with autogenous bone. So just look for Dr. Frank Zastrow. And so it's now autumn, a lot of travels, a lot of conferences, and that's actually always very nice to meet many colleagues there and discuss in person. So I could not do this without my clinic team, and I'm very grateful to them that they are there when I'm again traveling and giving lectures or courses. And we are actually offering in our clinic not only surgery, we are having from A to C, everything. Also, we have our own laboratory with milling machines, master technicians, specialists in endodontics, all these fields. And me and my colleague, who's maxillofacial surgeon, we are doing mainly then the surgical part there in the south of Germany. And I was starting probably like all of us with bone substitutes. And I mean, this is a kind of brainwash from the industry. Of course, I understand this is a multi-billion-dollar business. I understand that, all of us started with that. I also had some good cases, but many cases are, not predictable. And the interesting thing, the first 5 years I worked only with the GBR bone substitutes, and I never trusted in it, though I wasn't working, and I haven't seen the technique of Professor Khoury yet. But you know the results. So you see here on the right side, first I put a layer of bone substitutes, then a membrane. Usually I also tagged it against, for stability reason. But if you have ever looked into these cases and opened maybe the flap after 5 to 6 months, you know the results. But sometimes we are hiding our eyes and we don't look at it. But the reason why we have in many cases after 5 years perimplantitis is definitely iatrogenic, dentist-made. Because if you look at this picture now, it looks nice. So you would maybe do just a small stitch incision after implant placement. But did you ever open the flap? Did you look how it looks like? This is for sure no bone. That means as soon as it has access actually to the mouth flora, to the bacteria, you might face problems because this material cannot defend itself. It's not also inductive as autogenous bone. So the key rule is actually to have at least 2 millimeter vital autogenous bone around your implant shoulder to secure long-term good results. And this is also why autogenous bone is the gold standard, because it initiates bone regeneration. It's also genetic. That means it has the ability for building new blood vessels. And of course, it also works osteoconductive as a framework or a scaffold. But still in many heads, there's this idea autogenous bone resorbs. Where does it come from? It comes from, let's say, the old concept. I don't say it's wrong. It can have also good results, but with these full cortical blocks, in many cases, you have these results. You see here, this was done in another clinic. The patient had a bicycle accident, also lost his teeth. Bone augmentation was done there. Then he became our patient. And I knew that they're working with full cortical blocks. When I want to place the implant, you saw the block is integrated, but completely white. And white bone means dead bone. And we know for sure that this is going to resolve over time, sooner or later. This is not the result we want to achieve. And that's why we are coming to the genius idea of Professor Khoury with the split bone block technique, more than 30 years old now. And what he did was actually working with thin blades, thin them out. So you have a block, you split it, you thin it out even more, you have chips, and that now comes the beauty of the chips into place. Because while we are having these particles, we have an enlarged surface. That means we have faster access of the blood vessels and the blood supply. That means this bone stays vital. And you know, maybe this results from lectures, from books, from everywhere, from social media. This is red bone. This is vital bone. You see, we have no resorption here. And this is actually what we want to have in the end. And now comes the most important take-home message of this whole webinar. This bone will stay stable. I know we learned usually from the industry or from the speakers paid from the industry that you have to mix it with substitutes, or you have to put layer on it with substitutes and a membrane. We never work with membranes, and there is no need to mix it with any bone substitutes. Of course, you have to give functional loading into the bone. That means you have to place implants, and then you will have wonderful long-term results in this vital bone. So, and also at least in Germany, and I also know this from other countries, from a legal perspective, as implantologists, we are obliged to inform our patients about the possibility of autologous bone reconstruction. That means it's not enough to say, so we can use here now cadaver bone, or if you feel like you want to have it, I'm asking you, do you want to have it for yourself? Or from the cow or whatever. So we are obliged also to tell the patient that there is also the possibility for working with autogenous bone. And when you look at PubMed, you find wonderful long-term results, 10-year follow-up studies, also with the vertical augmentation. So one study I want to share here, 10-year clinical study in the mandible. So the mean vertical gain dimension with purely autogenous bone was 7.6 millimeter. You see it here. So almost 8 millimeter on average, which I think is amazing. And after 5 years, we have here less than 1 millimeter bone resorption in the height, less than 1 millimeter. So it's as physiological bone loss. And after 10 years, 0.75 millimeter vertical bone loss only. So, and we are talking about really big vertical bone augmentation. You see how powerful autogenous bone is. So we can state the split bone block technique, SBBT, by Professor Khoury is a very reliable technique. But what are the main challenges with conventional bone block harvesting? And of course, it comes to the point that usually when we are doing these fracture lines, so we are doing usually 3 to 4 cuts. Sometimes you can do, as you see it here, crestally, also small perforations. So that means overall we are cutting 10%, and the other 90% are broken out, as you see it here. And usually it breaks between the cortical part and the sponges part. So that means it's inducing more or less bleeding. Of course, you could do this theoretically also all with the, for example, piezo surgery. But then it doesn't take 20 to 30 minutes, but more 40 minutes. So, and chair time, I mean, if you want to work economically, is of course an important fact. So cutting lines 10%, the other 90% are usually broken out. And to summarize, harvesting maybe 15 to 20 minutes, with piezo surgery maybe a little bit more. Hammering needed, bleeding from marrow. We have a cortical sponges block, splitting is needed. So straight edged plates. So we have edges that have to be removed if possible. Of course, in our courses, we are training how to do it as low with lower invasiveness. And of course, it's a learning curve you have to undergo. But still, I mean, for bigger bone augmentation, this is the only way how to do it. So only then you have the gold standard and really, very predictable, safe results. But in which cases I was also like struggling a little bit with the fact to go here for a block with small dehiscence defects or with single tooth defects. I mean, here you might say, by the way, this is not a periimplantitis case. So this is a case where I plan to do bone augmentation and implant placement simultaneously. So here you might say, why not just place it a little bit deeper? But at least when we are looking to the frontal implant, just place it deeper. Yeah, I think we are coming here to some limits. So, and I want to show now an alternative. And first I want to ask you a question. What if there would be such an easy method that we can collect bone plates within seconds? That sounds like magic, right? Without the need of hammering or bleeding from marrow anymore. And at least when we are replacing just one word, plates by cylinders, I'm sure many of you have used it already, a trephine. So usually maybe 3-4 millimeter diameter, maybe for preparing also the osteotomy for your implant. You have these small cylinders, you have the small also carrots, and you can fix them with screws, usually via a clamping defect as you see it here. And usually, so this is also working, but usually we have some more resorption. It's very, very for small defects because the form is not like a plate. So, but this is still working, or some might know also, or some are calling it Audi technique or Olympic technique. So you're usually going to the retromolar area with a bigger trephine, maybe 4 to 5 or 5 to 6 millimeter. And but what is, the downside? In the end, we are having the same morbidity as a block, but no longer a coherent piece, a connected piece. So, but loose segments. That means this is what you have. You cannot work with it. You still have to crush it. That means in the end, you have only particles. So, and that for sure needs stabilization. That means you have to work again with a membrane. This membrane has the risk of exposure. And so that's why I ask myself the question, why not use the bone itself for stabilization? And also 3 more questions. Can we collect, because the first idea I had was the trephine is wonderful. We all agree this is a fast way, right? The only challenge we have, even with small trephines, is the overheating problem. But my idea was, can we collect big bone shells with the trephine? Not carrots or cylinder, really shells or plates. And let's see, my idea I had 9.5 years ago. It took so long time from the idea actually to bring it to life. So instead of working with a like medium-sized trephine, like 5 millimeter maybe, I used a big trephine, more than 10 millimeter. And I placed this trephine not in the middle on the crest, but really on the edge, that we can really collect only a shell with a thickness of 2 millimeter only. That means we don't have the need of splitting it anymore. And you see here my first trials 9 years ago. So that's how everything started. I invite you also to try it, but I can tell you 2 things. First, you need a very disciplined assistance. And even if this is the case, you see here probably, because 10% are inside the bone, 90% are outside the bone. It's very easy actually to injure the tissue. And this is not even the main challenge. The main challenge is we don't have a control over the vector, over the angle of the trephine. So there is the risk that we are going too deep into the bone and take a risk for the nerve. Of course, this is what we want to prevent. But I think we can all agree this is now much faster because now 90% are cut and only the last 10% are broken out. So we are able to collect bone shells with the trephine, but some other problems or challenges came now into play, which are how to protect the soft tissue and how to protect the nerve. And let's see if I also found a solution for that. And overall, it's not written here, but how to overcome the overheating problem. Because when we are really talking about a more than 10 millimeter big trephine, of course, you can imagine this is really causing a lot of heat. And here you see already the solution I had, the idea I had 9.5 years ago to combine a trephine with a protector. And you see here 2015. And actually this helps you to protect now the soft tissue injury from soft tissue injury and also from nerve injury. Why? I will show you in a few moments. You see here the first prototypes more than 13 prototypes over the last 9 years. And a lot of questions had to be answered. So how should be the surface? How do we overcome the overheating problem? How should be the coating? Should we use teeth or diamond coating? What is most efficient? What sizes should we use? How to overcome the overheating problem? You see, the solution we chose was to add an internal irrigation, and that was actually then the solution for that. And also we for more stability reason, we have an inner mandrel that contains the internal irrigation, and also a ceramic bearing, so also to overcome the overheating. And you see a lot of studies with the university clinics and so on and so on. And now I can I'm a little bit also excited and also a little bit proud also to show you, after so long time working on that project, the solution. So which is the Semilunar Technique. That's how we are calling the technique. That means 10% of the trachea are inside the bone, while 90% of the trachea are outside the bone. Means with the protector, we have now the protection from soft tissue injury. And now, I told it to you before, I give you the solution. The protector actually also prevents from going deeper. It's like a stop on both sides because you have support here on both sides. That means you cannot go deeper into the bone. That means in the end, you have your 2 millimeter thick shell without the risk to go too deep into the bone. It's really like peeling an apple, and that you don't have any risk for the nerve. And you see here in real time, actually, the Semilunar Technique. You will also see in a few moments why I'm calling it Semilunar Technique, because the shell really has this nice round, which has another great advantages: reduced exposure rate. And in the end, the augmentation looks really very physiological, very natural. And you see in the end, I tilt it slightly to the side. And it's an intracortical shell, as you see it here. It's an intracortical shell. That means the spongeous bone, the marrow part, is not opened. That means you can really take several shells. It's a clean cut. You can take several shells next to each other, usually 3 shells from one external oblique line. And we actually skip the block and go right to the shell. Also no need for splitting anymore. So with this technique, actually, we solved all the challenges we had. We are able now to collect shells with the trachea. We are able to protect the soft tissue. We are also able to protect the nerve from injury because it's like a stop. We cannot go deeper into the bone. And we overcame the big overheating problem by putting an internal irrigation inside. And here you see actually the summary. We are calling it Semilunar Technique. As a slogan, I was thinking about just peel it. I even got, because I trademarked it, a letter from Nike, no joke, by the way. And the length of these shells is 17.5 millimeter, depending, of course, and of the anatomy, depending if it's more rounded or if it goes straight downwards, that you can collect the maximum long shell. And I mean, in the end, the idea might sound trivial, trachea with protector, but to bring it to life was a long journey. And meanwhile, we have in more than 60 countries patents. And also another thought I wanted to share with you is this. I mean, we all use the safe scraper. So I'm a big fan of the safe scraper. But what are we doing here? I mean, if we have a closer look, it's actually the same idea, just that we are using here our muscle force. So the scrapings have also a half moon form, if you would look on them under the microscope. That means that we have half moon shaped scrapings. So the logical consequence out of that is actually to work with a drill or with a trephine, actually, to be more specific. So I think it's just like the safe scraper, and also regarding how easy it is in big. Quick repetition, block harvesting. So harvesting in 15 to 20 minutes and so on. We had it, the Semilunar Technique. Now, of course, much faster. Maybe not always like less than 1 minute, but much faster. So no hammering needed. So it's less invasive for the patient. We have no bleeding from the bone because it's an intracortical shell. We skip actually the invasive step of the block and go right to the blade. That means also no splitting needed anymore. That means reduced chair time. You have a perfectly rounded plate. You will see the cases in a few moments. We are really minimal invasive. It's actually, like the safe scraper, as I said before, no bleeding and easier. It's still a learning curve. So it's that you should try it before, but of course the learning curve not comparable with taking bone block. And still, don't get me wrong, I don't say bone blocks are wrong. No, I also use bone blocks if it comes to big bone augmentation, but if you have maybe one tooth missing or two teeth missing, I think this is the alternative to go. And back to this case, I repeat, it's not a perimplantitis case. I wanted to do here bone augmentation with implant placement all together. So what I chose here, of course, was actually the advantage of this nice balcony. This bone is made for us, like Professor Khoury always likes to say. So take advantage from the bone you have here, just peel it. You have a wonderful shell. And the rest is actually same as you know it from the split bone block technique, just with a simplified harvesting part. So you have your shells, you see they are slightly rounded. And what we're using here are our titanium mini screws. They are specially designed for these small shells, 1 millimeter diameter. And they are anodized, titanium anodized, that they don't osseointegrate. So with a perfect connection. And after 4 months, we are usually not waiting longer than 4 months, we can remove the screws. So the anodization prevents from osseointegration. It's a hex connection, and the space is filled then with the chips, as you know it from all the cases you might have seen already with the split bone block technique. The concept is exactly the same. And after only 4 months, we are not waiting longer. We are also, by the way, not working with membranes. I said it before. And there's also no need for decortication. By the way, I know, especially those who are attending maybe first time a webinar about autogenous bone, this might be a little bit overwhelming. A lot of new information, as it was for me when I saw first time Professor Khoury on a big conference. And actually on this conference decided spontaneously to work in his clinic. So it was actually planned that I go into the practice of my father, but it was like an epiphany, like an enlightenment. And I thought, okay, I have to learn this concept. So if you have any question, that's what I wanted to say. Just put your question into the Q&A only field. In the end, we will do question and only session. So please put all your question in the Q&A only field, what you find next to the chat, to any questions you have. Good. I think the main indication to work with the Semilunar technique and the easy bone collector are single tooth defects, especially also in the aesthetic area, because this is really demanding. And the goal is actually to reconstruct the Eugae alveolaria in that area. And what could work better here than these rounded shells? Now you see, it really comes all together now. So not only simplified harvesting, also you have now these wonderful, rounded shells that give you actually a more natural possibility for reconstruction. The access is done same as we are doing it with the block harvesting. So you start on the ramus, go then towards the tooth, change towards the vestibule, and go then forward. And you see here, I took already one shell. This is another shell I took. On the right side, you see the markings. Each marking is 2 millimeter. That means you always know also how deep you are. We need internal irrigation for that. And this is crucial actually to overcome the problem of overheating. So internal irrigation. And if the protector touches the bone, then you can stop. And in the end, you tilt it slightly to the side. That means it also breaks now in the apical area, and then you can just remove it without bringing any force on it. And you have your shells, as I said, 17.5 millimeter long, 8 millimeter wide, that you can also use them occlusally for vertical augmentation. That was the idea, to have really this nice width of 8 millimeter. But in this case, of course, you see here lateral augmentation in the aesthetic area. And another beautiful thing is because it's an intracortical shell, you can also collect now chips from the donor side. So just use the safe scraper and you will see the safe scraper fits actually perfectly into the donor side. The concept, as you know it from the split bone probe technique, you're placing your shells on distance. You're creating like a biological container. This space is filled in with the chips, nicely condense them, no membrane, save the money. And yeah, then in this case, we combine it with a palatal pedicle flap to increase the volume and to have also a second protection layer for the underlying augmented bone. And one thought I had, I was laughing when I was thinking about it. I mean, those of you who like fantasy movies, or maybe have kids who like this kind of movies, you might have seen this guy, Crude. So we might even call it Crude technique with these two screws. But yeah, enough jokes. Back to the case. You see the result after 3.5 to 4 months. No resorption, autogenous, red bone, vascularized bone. You can feel safe if you're placing your implant inside here. So definitely more than the 2 millimeter I said before, but that's the minimum you should have on all sides. Why? Because the minimum width you need that the blood vessels can grow through is 1.5 to 2 millimeter. So if you have just 1 millimeter, sometimes this happens when you do splitting and you have just this 1 millimeter, this will resorb. You will end up in the end with a recession. You might handle that somehow with soft tissue management, but do it right from the first beginning. And the idea is really to give you now a tool into the hand that, you can place more implants also in areas from now on where the bone is reduced, that you don't have to plan around the bone deficiency. I want you to be able now to build defects, to reconstruct defects in a very predictable way. 49-year-old female patient, also missing tooth in the aesthetic area. The 1-2 had to be removed. You see here why. And we are facing now a lateral defect. See it here on the CBCT. So the idea was, of course, I mean, these defects have a mesiodistal length from maybe 10 millimeter. So the length of the easy bone collector with a large 17.5 millimeter might be even here too big, but we also have different sizes. We have also small, regular, large. Large is more for molars, small is usually for aesthetic area. So we have these trephines in different sizes. And you see here again, the harvesting. And it depends now on the anatomy of the external oblique line. So if it goes straight downwards, you can take like a wonderful shell. In the end, tilt the trephine slightly to the side that it breaks apically, and then you can just remove it. If it's slightly convex and you go down with the trephine, then the shell might fall also into the trephine or into the into the protector in the end, which is also not a problem. You can just easily remove it from there, as you will see it in a few moments in this video. And as I said before, if the protector touches the bone, then don't continue, stop rotating, and just remove it. And you see here it was falling into the trephine, but there are small openings on the side that you can just remove it from here. You see, sorry when I'm so excited, but it's my baby. It's something I had in mind so long time, but these shells also have like, I think, a wonderful quality. When I shared these cases first time, no one believed me that this is autogenous because it looks so clean. And, but we know now why it looks so clean, because it's a clean cut just from a trephine, though in the end, it's a shell. And before you remember, I used the shell vertically. Of course, you can also place it horizontally, up to you. I recommend you to use always 2 screws for 1 bone shell to have no risk of rotation. So we don't want to take any risk that it's rotating. But of course, I mean, especially when you're a little bit advanced, in some cases, it's also enough to work with only 1 screw. But in the beginning, definitely 2 screws until you get a feeling for that. You see here the result in the end. You also see here a small crack. So also maybe here. And yeah, so it's very important that when you're going in with a drill, that you go maybe 3-4 times in and out. And when you go in, especially in dense bone with a screw, that yeah, you have a passive fit. So don't never try to squeeze in the screws. If it's maybe a little bit too much tension, just go back, go with the screw, go in with the drills a couple of more times, and then try again. You should have a passive fit. And for example, this system, it's called titanium mini screws, has a special design to have a special stability in these very thin shells. So the shell, remember, is 2 millimeter thick. So that means you still should thin it out to 1 millimeter, because we also need the chips, obviously. So the half of the part is of the chips is usually collected from the shells. The other half maybe from intraorally from the donor side, because now we have these small half moon defects. And you see the results. I'm sure, as most of you didn't work with blocks, I'm sure that you don't have these results. At least I didn't have it when I worked with GBR. Now it's a little bit provocative maybe, but when I had like a successful result, it still looked like a tumor. So I mean, you have this white stuff and everything. Sometimes we can remove half of it. This is autogenous bone. This is real bone. If you want to become a real bone bearer, this is the way to go. And the beauty is that we never have to wait longer than 3.5 to 4 months. So it's even possible after 3 months, but then you have to be also a little bit advanced, because the bone is maybe a little bit weak. You can work in it, but I would wait a little bit longer. And you see here the final results. Straightforward case as we do it every day in our clinic, and probably you same. And I showed you now cases where 1 tooth was missing. What if 2 teeth are missing? Again, for big atrophied jaws, you still need to go for blocks. And this is also what we are teaching in our classes. So we have in person and also online. And but for a single tooth defect, or if 2 teeth missing, which are more than 60% of the cases actually, this is an alternative. You can place 2 shells next to each other. That means, of course, you need 2 more screws. With a full block, you would only need 2 screws. On distance, we never have to build more bone than we need. So maximum is 8 millimeter, because we have hardly any resorption. Not like those times when I was working with GBR. I have to build double amount with a high exposure rate again, because I knew it's all shrinking down, and even over time, it's getting less. And if you would not see the screws now here in this augmented bone, probably you would not even see that this is augmented bone. It looks with this rounding so physiologic. So you can place more implants now, or you can place implants better, and also you can place more implants if you know how to build bone in areas with reduced bone. And in the most of the cases, we are facing actually a centripetal resorption. That means bone is only missing on the buccal side. But in some cases, especially when we are doing backward planning, and all of us should do that, planning is so important. So you might face the situation like in this case that we have to build bone from both sides, from palatally and from buccally. So you see here again, the use of the easy bone collector. We take a couple of shells from the retromolar area. This is also the main indication for the use of the Semilunar technique, to go for the retromolar area, because here we have this nice balcony. Take advantage from it. The external oblique line is made for us. I'm citing now Professor Khoury. And you see here the nice shells. This is the way how we are scraping it. You take a ronger, scrape it on a glass plate with the safe scraper. So we are scraping it from 2 millimeter to 1 millimeter, because we need the chips. I mean, I also know, some colleagues, they are taking a couple of shells and crushing them actually then in the bone crusher or in the bone mill. I mean, there are different options. Now you have actually the possibility to work with shells in an easy way. And if you do this 2-3 times, you will see it's much easier to fix actually these shells on the crest, then working with the substitutes, so which are everywhere, but not in the place where you want them, especially when you're closing the flap, you know, everything is pushed down and yeah, won't stay there. It's very important when you're working with chips that you're condensing the chips in the very end. And again, this is the result after 3.5 to 4 months. Red bone, vascularized bone. This is stable. Placed here another 2 implants. So you see the shells really, yeah, I say almost 2 centimeters, which is quite a long. And even if you have some small gaps on both sides, so this is also not a problem. Apical reposition flap for a second stage surgery. CAD-CAM milled, screw retained crowns from our laboratory. And yeah, you see the second secret actually, not only do you have autogenous bone, vital bone around your implants, 2 millimeter, no, also keratinized and fixed mucosa. So in most of the cases, we are adding actually some overall 6 soft tissue techniques to manage almost 100% of all, even the most challenging cases. And yeah, one more case, time is running, where I was experimenting a little bit with the Semilunar technique, because I was removing actually this tooth. You saw it, it was destroyed. I was waiting actually already 2 to 3 months until I wanted to place the implant. But now you saw it was not regenerated. So obviously patient with a not so good regeneration potential. And we all know if the patient doesn't have a good regeneration potential, bone substitutes never work because they are pure osteoconductive. They work like a framework or a scaffold. That means if there's no regeneration coming from the walls, then you will fail. That means we need osteoinductive material to overcome these cases. And the challenge here was actually, I can show it here. I mean, not only now this big alveole that didn't recover, but also very close to the nerve. So just 1.5 to 2 millimeter, maybe max. So the idea was now also to collect a semilunar shell. I took a shorter one, worked with a template, and then I filled actually the gap or the alveole with the bone chips. And I used the shell as a cover. And I wanted to place the implant now also same time. And this is possible because now I had like a bicortical stabilization apically, even if there was just 1.5 millimeter bone above the nerve, and crestally. I used the trephine in this case because the trephine usually has a less vibration than a drill. And here I was able now to place the implant with good stability. So the beauty also in this screw system is that they are made from titanium. That means also in this case, actually, I didn't find the screw, I just left it because of titanium. So it doesn't show the risk of corrosion as we have it with steel, screws from steel. And yeah, also now some cases from our students.
I recently had the chance to try the new easy bone collector from Dr. Frank Zastrow, and I have to say it exceeded my expectations. What really stood out to me was how fast and efficient it worked. It only took me a few seconds to gain 2 block shells. I was able to collect 2 bone shells in a matter of seconds. That is something I've never experienced with other tools. Despite its speed, it didn't feel rough to me. It was really very, very gentle procedure, and the patient didn't feel any pain or any strong vibration at all. I really highly recommend this new tool because it makes it much more easier to collect bone blocks from the retromandibular area, and the patient has a very, very comfortable feeling because there is less operation time, and I also didn't see a big swelling after the operation.
So another colleague, many colleagues meanwhile tried the easy bone collector,
Today we will use this new technology, this smart instrument of Dr. Frank Zastrow for bone harvesting. Easy bone collector. This is the instrument. You can see that cells for minimally invasive harvesting of bone shells from external oblique. I did some weakening at the base, so that not result with a shorter shell if the fracture line was more coronary. And you can see distal part will need to early this line, and the mesial part will be not fully inserted, and so this will result in a shorter bone shell than we expected.
So this is maybe the future of all jaws from the patient, like a wave design that, because so many colleagues are starting now with using the Semilunar technique. I'm very proud of that. And to simplify the procedure. By the way, if you want to see this case also and also other cases, go to our YouTube and watch the case from Dr. Krasimir Slatev. He also had some good tips how to use the Easy Bone Collector in a proper way. And we are coming now to conclusion, but we are not finished yet. Don't worry. But we are coming actually to conclusion regarding these cases. Using autogenous bone reconstruction with the shell technique enables long-term stable results, even in vertical defects due to its osteoinductive potential. As implantologists, we are obliged to inform our patients about the possibility of autogenous bone reconstruction. And the Semilunar technique simplifies intraoral bone shell harvesting. Dentists can offer their patients now autogenous bone reconstruction with the gold standard for long-lasting results. So when you have, and probably all of you have seen the Khoury technique, the split bone block technique, you were maybe scared to start. Now is your chance actually to start working with autogenous bone and become a real bone builder. And we are coming now to this special offer you definitely cannot refuse because it's the launch offer for the Easy Bone Collector. But before we will show, I will show you a very quick small video. So, are you interested now in getting your hands on the Easy Bone Collector? Then please write the number 1 into the chat. So if you want to get now more information about how to get your hands on this game-changing, cutting-edge medical device, please put the number 1 into the chat. And I would be pleased, of course, to give you more information about this once in a lifetime offer we have prepared for you. And I see already a lot of number 1s coming in. Thanks so much for your trust. I was working really, really hard for the last 10 years to give you this technology into the hands. And thanks again for your trust. All who are interested in getting more information, put the number 1 into the chat. And now we are coming to this special offer today. So our special launch offer, we are calling it, what else? The Real Bone Builders package. So it contains the so-called ready to go box. So after that, you are ready to go into this field. So it contains 9 easy bone collectors, 18 titanium mini screws. And yeah, what is included actually in this ready to go box? So it has 3 easy bone collectors, small. As I said before, these are for the aesthetic area. We have 3 easy bone collector, regular. So for medium size, so they differentiate a little bit between the sizes. I will show you the sizes later, what shells you can collect, and large more for the molar area. So the screws, I mean, this is what you know for 6, 8, and 10 millimeter. It's always a 6-pack, 6 in one. That means you can treat 9 patients actually with that. And the Trephine covers actually 90% of the protector. You see here the price for one easy bone collector is €200. And yeah, so we have small length of 12.5 millimeter, regular length of 15 millimeter, and large length of 17.5 millimeter. As it comes with the internal irrigation, because yeah, the European regulations do not allow that. So titanium mini screws, so they have a diameter of 1 millimeter. I think it's yeah, maybe the only system in Europe I would know made from titanium in this yeah, so thin for better biocompatibility. You can leave it, but it's anodized that yeah, if you remove it, it's going actually quite easily, and a perfect connection, I would say. This is also what we worked the last years on, that to have a perfect connection. So we have yeah, not only the ready to go box, with it comes the online hands-on training. What is meant with that? It's weekly hands-on training, because I said already, the learning curve is a smaller one than with the block, but it's still a learning curve. And what else is included is our weekly live mentorship. And actually, we also call it Netflix for bone augmentation. So all the things I told you now in this small webinar, and yeah, 100% more is actually in this, yeah, included all in this small, we are calling it Elite Masterclass. Weekly hands-on training, weekly live mentorship, and yeah, so this is how it looks like.
Masterclass live calls. So, and here you will also meet the other masterclass students from all over the world, top surgeons from all over the world, and we will discuss cases and also your individual cases.
Because you might have seen it. You're going to a course, to a weekend course. You're paying maybe yeah, a couple of €1,000, and after 2 months, your first patient is showing up. First of all, you have forgotten all the theory, and even if you remember some of the theory, it's really hard to adapt it to your individual case, to do the transfer. What exactly should you do here? What soft tissue approach? What, yeah, how does the retromolar area look like? The donor side, is the nerve close and everything. And here we are taking you on the hand. You have your own mentor, and I will tell you, I will give you tips how to do it better. And of course, we're discussing also cases. Meanwhile, a lot of cases now also with the Semilunar Technique, with the easy bone collector. Kati was doing actually just her second block, and see what she's saying.
I think a nice defect for the first time.
Mm-hmm.
And this was the beginning. I will just, yeah, I decided to use the larger one.
Oh, it's a beautiful shell you collected. Congrats.
So this was my shell, which I managed to collect. This is the place where I took it from, and yeah, this is the final thing. I had enough bone chips. Then when I was looking at the photos, it shouldn't be any longer here, I think. Maybe it would be a little bit more here, but I used the bone chips. The first feelings which I had were it's really easier using the microsaw. It was just simpler. I didn't have to use so much different things. So it was faster, definitely. It was, I think, more comfortable for the patient. And yeah, I hope it ends up with a success.
Definitely, it will end up with a success, because the predictability working with autogenous bone is not comparable with GBR. And finally, and this is something I'm super excited about also to introduce it to you, this is our starter box. It includes all the equipment you need for the online hands-on training. That means you don't have to travel. Of course, you can travel. We also offer in-person hands-on courses, like big ones, where we do also advanced soft tissue training and so on and so on. But for this technique, actually, so you get the equipment for your online hands-on training, and also including the screw system, the titanium mini screw system I showed you before, for clinical use. So overall, this is the package, everything you need to become a real bone builder. And you see here the fixation system with a screwdriver and the TMS drills. These are actually with 4 drills, and all the training equipment you need, like jaws and training easy bone collector and everything. And then you're ready to do the training. And this is really a lot of fun. Every week we are having our online hands-on training. So the starter box is your gateway to our live online hands-on training. And this is how it looks like. So it includes, happy colleagues, includes the training easy bone collector. I mentioned already, training screws, the fixation system also for clinical use. And this is how it looks like with the drills. 0.9 millimeter diameter for the 1 millimeter screws, screwdriver, and this is how our online hands-on trainings look like. Good. Yeah, I hope you're also a little bit excited now, because we are coming now to the special webinar launch offer. And it's a one-time offer. This is, an amazing offer, won't come again. Valid 24 hours only. That means you have to act if you really want to go this way. And to summarize, we are having the ready-to-go box, including 9 easy bone collectors, 18 titanium mini screws, the online hands-on training, with the live mentorship and Netflix for bone augmentation, as we say, everything you need, all the theory you need to really, to grow actually your knowledge in biological bone augmentation with autogenous bone. The starter box with equipment for the online hands-on training, the screw system for clinical use, everything you need, and we are coming now to your investment. And I know this sounds crazy, but in this package, we are giving again 10%. I really wanted to make it a no-brainer, that you don't have to think if we are bringing this offer now to the table. That means 1 easy bone collector is just 180 euro. That means, for the ready-to-go box, overall with the screws and easy bone collector, your investment is 2,187 euro. You can treat 9 patients with that. And I'm sure when you, maybe paid like for piezo surgery, 10 or 12K. I'm asking you, how many times did you use it already for taking blocks? The online hands-on training has a usual price of 3,000, and my team said you can't do that. But I said, this time, I want to give something back now to the community. You're here, it's your precious time, and this time I want really to give something back. So our training, which is usually 3,000 euro, and probably many colleagues who are very, also pleased with that. It comes actually for free in this package. And the starter box goes down from 2,000 euro to 1,000 euro, which is actually even the price for the fixation system. But it comes all together with the training. So all together in this package, we are having a final investigation from 3,187 euro, special launch offer. And I'm sure that per month, you're spending more money for bone substitutes. And we know these cases, usually you have to redo many of them with very reliable results. And you should find now on the site our special offer So, when you click it, get your special offer now. You will be forwarded actually to this page, finally available, the Easy Bone Collector. And if you scroll down, you can just make your appointment with our team. They will guide you then through the shop and choose your appointment, your time. So 24 hours doesn't mean that it has to be within the next 24 hours. It just means you have to make your booking within the 24 hours. So until tomorrow evening, you should do your booking with our team to ensure that you are getting this very special offer. And you see, it just takes actually 2 minutes to register, also with your name and your contact data. And I hope that many of you are same excited as our students and colleagues who are starting working now on a daily basis with the Easy Bone Collector and the Semilunar Technique, like Dr. Valet Mirza Bailing.
I'm happy that I was one of the first to able to use this Easy Bone Collector. I have known Dr. Zastrow since 2019, and since then I have always worked with autologs bone and use the blocks. I have waited about 5 years for this Easy Bone Collector. Today we had second operation with Easy Bone Collector, and it was very simple. We have saved the time, we have saved the energy, and it is very fun.
So you can just click actually the link or the picture on the right side. Of course, you can also go to jointeambone.net/session. That's actually the page. You will find it. And get your special offer now. Time is starting now. And I'm excited now to look to your questions. So we are going to the Q&A only field. So I will see how many questions we have, because I promised you that we are going now into the questions, and I see there are a lot of questions. Wow. So very big engagement. That's really amazing. Thank you so much for your interest. So Baron is asking, are bone collector for one-time use only? Yes, they have internal irrigation, and to ensure that it really cuts always, like the sharpness, and also the internal irrigation, it's not sterilizable. But I think, very small investment if you compare it also with other materials. Andre Taxera is asking, what about temperature rising at the surgical side of the bone? How do you prevent the factor that it's important too? Exactly, that's the point. Exactly, that's what we're working so long time on. I had this problem with overheating in the very first step 9 years ago, when I was working with this full trafines, but with internal irrigation, actually, you overcome the problem of overheating. So internal irrigation was actually the key. Eftimios is asking, without internal irrigation is dangerous, and what's the speed of harvesting? So because of that, we can really go up to 1,500 rounds per minute. So really fast, because we have the internal irrigation. And without that, I would definitely not recommend you. Exactly. So Mayola is asking, is the distribution of these products in Albania? So just book your call also with my team, and they will tell you actually how to get it there. Christopher Maton is asking, are these single use? Exactly, they are single use. Roman is asking, what type of mini screw system do you prefer? yeah, the titanium mini screws I just showed you. This is the only system in the market, as far as I know, made from titanium, 1 millimeter diameter, really give a perfect stability in these very thin shells. And Mayo is asking, what kind of incision do you use, please, for taking semilunar bone from first mandibular premolar till? So we are starting on the ramus. So we are going then towards the last tooth, but not into the sulcus. We are changing actually the angle then towards the vestibule and extending then to the mesial by staying 2 millimeters away from the keratinized mucosa. By the way, all these things will be in the training videos, which come in this special package actually for free to you. So all the explanations, how to work with split bone block technique, how to work with semilunar technique, it's all included actually also in this Real Bone Builders package, with the videos, with whiteboards, with everything you need to understand the techniques to work with autogenous bone. So Mayola is asking, are the contraindications for similar techniques, please? It seems not a problem to have too much mandibular bone width. Contraindications, I would say like same as we have also for placing implants. I mean, if the patient is having IV bisphosphonates, probably not do bone augmentation or implant placement. But I mean, it's so minimal invasive now. You're really staying cortically. It's an intracortical shell, same like the safe scraper. So I would say when you can use the safe scraper, you can also use semilunar shells. So hardly any contraindications, or at least same like for placing implants. So Ryan is asking, why no need for membrane autologous grafting? So I'm new to these concepts. Because membranes are actually invented from the bone substitutes industry. So when it started 60 years ago, working with autogenous bone blocks, what was the start? Actually, there were also no membranes on the market. Then some smart businessmen come on the idea, yeah, why not make money with it? Why not sell substitutes, which have not the similar quality, but it's a multi-billion-dollar business, which is also okay. I mean, yeah, when you're working with autogenous bone, you have seen maybe the case in the very beginning when I was working with a full cortical block. Why is this white bone? Because the blood supply, the revascularization takes too long time. This is the reason. So if we are using now autogenous bone and we are putting a membrane over it, we are also cutting the blood supply. And if we don't work with membranes, there is actually no chance, no risk that there is infiltration of soft tissue. So it's different than working with bone substitutes. If you're working with bone substitutes, you are not using a membrane, then you have ingrowth and infiltration of soft tissue. You don't have that when you're working with autogenous bone. Or maybe just a little bit, maybe 1 of 10 cases or 5 cases, maybe just a little bit, but you don't need it. You know the cases maybe from Instagram or social media or from the book from Professor Khoury and so on. So we never work with membranes. We don't cut the blood supply and save the money. Val is asking, is the Easy Bone Collector reusable? No, it's a single use. Is it possible to re-sterilize without ruining it? Unfortunately not. So, but I think 180 euro is, yeah, so compared also to other materials. And regarding the quality, you're getting actually a very small invest. So Mayola is asking, in what kind of bone defect do you use Semilunar Technique, please? How big it should be not to be resolved with simple guided bone regeneration? I'm using it actually in all cases which are having, when you have a single tooth defect or yeah, 2 teeth are missing. So even my colleague who is maxillofacial surgeon who really know to do how to do big bone augmentation because of the speed, he's using the Semilunar technique because it makes things faster. So as I said before, we have different sizes, small, regular, large. The small is 12.5 millimeter long, usually for frontal teeth. The largest for molar teeth, 17.5 millimeter long. So this is how we choose then the right size for the Easy Bone Collector. So if it's more length of the defect, of course, you have the possibility, as you have seen it also in the case, to place 2 shells next to each other, or you can also go for a block. Round per minute, approximately 1,500 up to 1,800 round per minute, because we have internal irrigation to overcome the overheating problem. So Lana is asking, is this possible to take the shell slightly mesially angulated to have a better access to the bone scraper later on the collected? Absolutely. So, but one thing you should keep in mind, but of course we also discuss this in our weekly live calls if you want to attend, and also in the case discussions. The Easy Bone Collector in the end has the protector. So if you're using, let's say, this is maybe the external oblique line, and you're going down now with the Easy Bone Collector, that means the stop is now here in the distal area. You see, because the protector is now the bone. That means in the mesial part, it's not completely. That means your shell is shorter than it should be. So that's the reason why you should adapt actually the vector or the angle of the Easy Bone Collector, how you want to have it. So in this way, for example, because then the protector everywhere hits or touches the bone on the same level. That means you have the maximum long shell. And of course, this also makes the scraping with the safe scraper in that same area easier. Hope that answers the question. But of course, I mean, like with every technique, so there should be some education behind. We are teaching all these things that you have good results at your patients. And yeah, in this very special offer, as you know, it's even for free. So Richard is asking, what is the right design of the flap for harvesting retromolar? I described this, I think, to another colleague before. Tana is asking, do we need to cover the bone area after the osteotomy? No, because it's really, you have a shell which has just 2 millimeter thickness. That means it's really a very superficial intracortical shell. That means you don't have to put anything there. No collagen sponge, of course, no bone substitute or something. Just leave it. So Sam Rodriguez is asking, can we use SLT for vertical augmentation? Yeah, I mean, because of the shortness of the webinar, I didn't show, but of course, yeah, we are also using it for vertical defects. So we have the right angle technique and we have the parallel technique. And yeah, these are the technique to go into the height. So Tanya is asking, do you advocate semilunar bone graft from posterior maxilla using special semilunar drills rather than block graft? Advocate similar from posterior maxilla using special. So it's indicated mainly for the retromolar area in the mandible as because of the bone quality, because we really have a nice D2 bone, while in the maxilla we might have the problem that we are not having good enough bone quality, maybe D3, D4 bone. And when we are using these cases, especially for maybe placing them out of the envelope, this might not bring enough good stability. So we recommend to go for the retromolar area in the mandible. So Malik, is the semilunar technique successful with the direct implantation? Absolutely. So that's what I showed also in this other case when we combined actually semilunar technique with immediate implant placement. So this is possible. And we have also many colleagues who are doing a lot of direct or immediate implant placement who are also combining it actually. So James Bateman is asking, what is the limit in terms of vertical and horizontal extension of the semilunar technique? In terms of vertical and horizontal extension of the semilunar technique? This depends actually. I mean, the limiting point is actually not the height of the defect. The limiting point is actually the bone peaks on the adjacent teeth. You can build bone only on the adjacent, on the bone on the adjacent teeth, not on the on the tooth itself or on the surface. So this is then not predictable. All these things you will also learn then in our online education. And this is the limiting part. Otherwise, I mean, yeah, there is no limit. So if you have really like a big vertical defect, let's say, but you have the bone peaks on both sides, that's not a problem. You can take, for example, 2 shells below each other. So you can also play around actually, vertically or horizontally, up to you. Good question. And last question, why do you need to in the market and tie it to the class? So exactly. The class comes now for free actually with this. So it's hard to believe, but it comes. So be quick and take advantage from this offer. And we are now in the end of this webinar, 1 hour, 10 minutes. I hope this information was fast enough. Thanks so much that still most of you are still in the call. I really appreciate that. I hope to see many of you next week online in our new class. And yeah, let's do then the online hands-on part together and discuss cases. Of course, we are also discussing many things in our live calls, which are also on a weekly base about soft tissue. We have really experts from all over the world. Meanwhile, almost 600 students in this class, and they're discussing wonderful cases on a regular basis. Everyone has actually his strengths and their specializations. So you have the chance now to become part actually of this community who's really helping each other. Because many times, I mean, colleagues do not have the chance to ask someone. So you're like fighting alone in your clinic. You don't have maybe colleagues, at least in most of the clinics or practices, to ask several things. And now you have the chance actually to become part of a group, and we are helping each other. And I would love to welcome you in our Real Bone Builders community. I wish you a wonderful evening, and hopefully see many of you there, and all the best. Take care. Bye. See you soon.